Hey everyone, I'm Dr. Divya Desa. Welcome back to my channel Ace Anatomy. In Anatomy in Practice series, I take anatomy beyond the books. I will show you how the anatomical concepts come to life in clinical practice, making anatomy all the more relevant, engaging and indispensable. So hit the subscribe, ring the bell and join me. Before we dive into the injuries of axillary nerve, let's have a quick recap of the anatomy of axillary nerve. So the axillary nerve with the root value of C5 and C6 arises from the posterior cord of the brachial plexus at the lower border of the subscapularis muscle. So it runs backwards, passes through the quadrangular space along with the posterior circumflex humeral vessels, and there it lies closer to the surgical neck of humerus, and it runs laterally and deep to the deltoid, divides into an anterior and posterior branch. Now this axillary nerve gives an articular branch to the shoulder joint. It gives muscular branches, that is through the anterior branch as well as to the posterior branch to the deltoid, and the posterior branch also supplies the teres minor muscle. It also gives cutaneous supply, that is the anterior branch supplies the skin over the deltoid, and this posterior branch it ends up as upper lateral cutaneous branch of arm to the supplying the skin of the lower lateral part of the deltoid muscle. The anterior fibers of the deltoid muscle, which is supplied by the axillary nerve, they are the flexors as well as the medial rotators. The posterior fibers, they are extensors as well as the lateral rotators, and the middle fibers, they bring about the abduction. They are the strong abductors from 15 to 90 degree. The axillary nerve can be damaged in inferior dislocation of shoulder joint as well as fracture of the surgical neck of humerus. So these two are the common causes for the axillary nerve injury. Now let's look at the clinical features of axillary nerve injury. So since axillary nerve has both motor supply as well as sensory supply, so in its injury we see both motor loss as well as sensory loss. So the motor loss is in the form of impaired abduction of shoulder joint, which is due to the paralysis of deltoid and teres minor muscle. And there is loss of the shoulder contour with the prominence of the greater tubercle of humerus, and this is because of wasting of the deltoid muscle. There is sensory loss also over the lower half of the deltoid region, and this is because of the involvement of the upper lateral cutaneous nerve of arm. The area of cutaneous supply of the axillary nerve is also known as the regimental badge area. So this is because traditionally the badges were placed on the uniforms in this area. So in injury of the axillary nerve, we see certain signs and symptoms in the regimental badge area, so which we call it as the regimental badge syndrome. So there is pain or numbness in that area. The muscle over there is weak, that is the deltoid muscle is weak, and there are sensations of pins and needles in the distribution of the axillary nerve. And that's a wrap for today's episode of Anatomy in Practice. I believe I helped you connect the dots between the theory and the clinical correlation. So if you found this video helpful, don't forget to like, share and subscribe. Hit the bell icon so that you never miss out on the next exciting exploration into the practical wonders of anatomy. See you in the next episode. Until then, happy learning.